Again, the common risk factors will be the hepatitis B, hepatitis C, heavy alcohol consumption, NAFLD, and inherited metabolic diseases like hemochromatosis, alpha-1 antitrypsin deficiency, glycogen storage disease, porphyria cutanea. These are the quite rare causes, and autoimmune hepatitis are also quite rare. Screening and surveillance will be people who are hepatitis B or C virus positive or be put on surveillance, and they should be put on quarterly ultrasound test, put on LFT test every 3 months, and follow up with alpha fetoprotein and other tumor markers. The population in which screening should be done will be the targeted population, which we mean to say will be the cirrhotic and hepatitis B virus, and we need to do an AFP also. In cases of level 2, screening can be done every 6 months, while in level 3, who are in higher risk, screening can be done in every 3 months also. The common diagnosis will be the clinical features include the abdominal pain, ascites, anorexia and weight loss, malaise, rarely bleeding, and encephalopathy is quite rare. Because of the liver's regenerative capacity, the encephalopathy part occurs quite late. The hepatocellular carcinoma acquires its blood supply from both hepatic artery and also the portal vein. While we need to understand the blood supply of the liver, more amount of blood flow is from the portal vein that satisfies the oxygenation criteria of the liver, because it is 2 to 3 liter per minute, and the flow rate is so high it can derive the nutrients from the portal vein also. This is a picture of HCC that is seen in the right lobe of the liver. CT scan picture. There is a comparison between the dynamic MRI and the spiral CT for the diagnosis of HCC. You will be able to see the washout in cases of HCC, while the sensitivity for a cytology is around 80 to 75%. The histology part is 61 to 89%. We will get a brief idea about the guidelines for the diagnosis of HCC. Basically, 2 imaging modalities are sufficient for diagnosing a HCC, that is a malignant tumor, rather than to go for a cytology either via a FNAC or a core biopsy. The recent guidelines suggest 2 investigations like either MRI and CT or an ultrasound plus CT are able to diagnose and give a typical imaging. No need to go for a biopsy. Only in cases which are atypical you plan for a biopsy. Various staging systems are there for hepatocellular carcinoma. We should understand there are various staging systems because there are still confusions that are prevailing in the management for HCC.